This is Erica Mello along with my co-host Susan Clinton, and this is our first inaugural podcast. It is called Tough to Treat, a physiotherapist guide to treating the complex patient. And both Susan and I see a lot of these types of patients, and we wanted to present our clinical reasoning, our evaluation, and treatment processes into a podcast series in terms of clinical case discussion and imparting sort of a think out of the box type of approach. We really hope you enjoy it, and thank you from the bottom of our hearts for listening. The first case is about a patient who had chronic low back pain, and she had seen the rounds of multiple providers, and ultimately the source of her problem was her neck. So I hope you enjoy it, and thanks again.
My name is Susan Clinton. I'm a physical therapist, and I'm in the Pittsburgh, Pennsylvania area, and I'm joined by my co-host, Erica Mello.
Hey, Susan.
Hi.
I'm so excited to be here on the podcast. And I'm actually, for people who do not know me, I'm a physical therapist in private practice here in New York City, where it is very, very foggy today, and I actually have the air conditioning on. But it is, I'm so psyched. It's our first podcast, and I hope everyone really enjoys it. And I, like Susan, tend to get the patients that are very complex, and we thought it would be a great idea to, just sort of talk about how to treat them, because I don't think there's a podcast out there that does this. So, and we have fun, and it'll be fun. It really will be.
Yeah. Erica and I found each other over social media, and we were actually put together by a common physical therapist friend about a complex patient. And we had so much fun discussing the ins and outs of, okay, where should we go next? What do we think about with this? And we started deciding that, we should meet on a monthly basis and, just kind of go over tough patients that we're kind of struggling with in our own practice. And then the idea of the podcast kind of grew out of that. So we are very excited to be doing this. I'm sorry it's foggy in New York. We have a very rare appearance of the sun in Pittsburgh. So
I know
welcome to spring.
I know it's been foggy all week, but yeah, no, it's amazing because I know people, we've both been members of different forums and groups online. And then by the time, the end of the day comes, you want to type in about your patient, you're like really exhausted, and I think that having a forum where people can hear us, whether they're working out or going to work or just sitting at home, just to talk about patients that are tough, and as opposed to just typing in, their own patients online, I think it'll be a lot of fun. So do you want to just dive into patients?
Yeah, let's dive in. I think you said you had somebody you wanted to start off with.
Yes, I did. I actually saw her. I have her chart right in front of me. It's crazy. I saw her a couple of years ago, and she is a female and about 55 years old. And she came to see me after seeing multiple physios and had been to GI doctors, and she'd been to, just osteopaths, and it's, sort of a typical scenario that you and I both see. So she had two chief complaints. One is she had right-sided PSIS pain, right-sided buttock pain, and sometimes it referred into the groin. And she also had left lateral hip pain, which now looking back on this, resolved on its own. Her main issue was this right buttock pain. She could not go up the stairs, she could not stand, and she could not sit. So her chief aggravating factor was she couldn't stand, and then the stairs, and then the sitting. And she also couldn't lie on her left side because of the hip pain. But because she was so complex, I decided I was just going to focus on the main issue, which was the right buttock pain. And what made her feel better was just sitting and, raising her leg up in the air, believe it, or like a knee extension, which was kind of weird. I'm like, okay, I think when she's over many years, she's been trying to do things that trying to make her feel better. She also told me that she was doing some of these typical pelvic floor exercises. I'm not a pelvic floor therapist, by the way, so as you are. So she was doing these typical, the typical exercises, and you can correct me if I'm wrong, the Kegels, and they were making her worse. And she probably was overdoing it a bazillion %, from what she told me. So her medical history, when you see a patient that has multiple issues, and she has a history, 2 years ago, she had a total hysterectomy, she had an abdominal infection, she had endometriosis, she, just was at her wit's end. She didn't have any trauma, no falls, no MVAs. She basically saw a chiropractor as well, was adjusted, what got worse after that. Her vocation was she was a researcher. And really her goal was she wanted to walk like 30 minutes and be able to sit in her car and drive to New Jersey where she worked. And I think when you see patients like this, just listening to their story and having them unburden themselves is therapeutic. And I don't believe, you can chime in, I don't believe that patients really want to get a treatment the first session. These patients, sometimes they do, but she just wanted some answers and education, right?
Right. I totally agree with that. I think one of the things that they're looking for is confirmation that you hear me and that you hear what's going on with me, and you actually can help me find solutions.
Right.
And I think that you and I are a little bit kind of blessed in our practices that we do get these very complex patients, but we also, they're coming to us because they're ready to make a change. They're not coming, I never get anybody walking in the door saying, I'm here because my doctor told me to come. They're here because they're seeking they're seeking out an individual who is really going to and are going to listen to them. And I think the story is 99% of the game here. I think there was a research article, I don't have it in front of me, but that at a typical primary care physician's office, as soon as the patient starts talking, the average rate of interruption was at 12 seconds.
Oh gosh.
So these these folks are, no one's listening. And I think that I agree with you that maybe not have to treat the first day is a little bit of a paradigm shift, but so much can be found out by just really sitting and listening and asking questions and asking about their goals. One of the things that I like that you were talking about that really struck me was not so much her pain, because she's had it for so long, so we know it's probably more of a central processing kind of issue, but her goals.
Right.
In many ways they're so practical, because I just want to be able to get to work, and I just want to be able to, what did you say, walk for 30 minutes?
Right.
Yeah, that's wonderful, because she's already scaled herself back. However, it's also very sad, because somewhere in there she's lost the joy in her life, because all she wants to do is get to work or walk 30 minutes. It's like she doesn't want to go dance. She doesn't want to sleep all night. But we have to go with what they give us in the beginning, and those are the most important things. So I love the way that you started off talking about, and I want to hear a little bit more about what you kind of figured out was sitting with her, because you said sitting with knee extension felt a little bit better.
Yes, and I was like, oh, that's kind of crazy. And I was thinking maybe reverse dural. I was like, because when I see a lot of patients who've got these she didn't have a wacky symptom. It's just right butt pain. That's really pretty common, right? Right. So, but with her history of the abdominal infections, the hysterectomy, the endometriosis, I've done a couple of the Baral courses, the visceral stuff, and they're fabulous. And I did a listening course as well, which I loved. And I've done, some work with Diane Lee and LJ Lee in their Discover Physio series about 5 years ago. So it's really sort of honed in my clinical reasoning process. And I was like, knee extension, that's really crazy. So what I ended up starting off with, I got her basic other, her ruled out red flags. I think that's pretty standard. We're not going to get into all that unless it's, really pertinent. I'm sure everybody listening to the podcast can do that. So, but for me, I don't know why I was honing in on these surgeries, because for her, and also she also wanted to sit in this lazy boy Barca lounger she had at home. And I think that was her thing. She wanted to sit and watch TV as well. Although she didn't mention it on the first visit, it came out several visits later. So what I did was, since standing was her issue, and I know people say, don't look at posture and standing and things like that. And if the patient's issue is standing, I look at standing. That's hello, right?
Right. Well, we may not want to look and call a posture bad, but what I think I tend to do is I want to know what's dominant, because we know that the central nervous system is going to set up efficient patterns of movement, whether they are patterns that continue to support the pain experience, or they're patterns that they just have adopted because of lifestyle, or they're patterns that they have adopted to avoid a pain experience, they're still dominant patterns. And if they continue to do the same thing over and over again, we're really not going to get much change. So I like that. You know, she needs to stand. We have to look at how are they standing and how can we change what's going on, and does that give them change in their symptoms as well?
Exactly. And I think with her, I don't believe she was completely hypermobile, but she definitely had some loose joints, you know, and I think that people like that, and myself I include in that category, I'm extremely flexible, is there you can compensate up to a certain point. Mm-hmm. And then you end up running out of options. And that's when they waltz into your door for the umpteenth time, or somebody else's door. And I think with her, she ran out of options. She couldn't compensate at the foot or the neck and you know, her knee or wherever. So basically what I did was, and I you know, this is going to be a bit of a biomechanical thing with me, but I do look at that in standing, since standing was her issue. Mm-hmm. So for any people who've done the visceral manipulation or visceral listening, I will just mention I do a general listening and standing where I put a fascial load on their head and then I feel where of the pull. And with her, it was right posterior, above and right at the level of the diaphragm. So for people who've done that, it just sort of confirms where I'm going to go. And they, you know, the rule is, you know, the body hugs the current lesion. And sometimes I'll get pulled elsewhere, but on her, I didn't. I got pulled right down into that spot. However, I do recheck that every so often because it, you know, causes and symptoms change from session to session, at least in my experience. So with her, what was interesting is that she was standing and her whole pelvis was twisted to the left. Okay, that was, you know, so you bear in mind right buttock pain. We call it, you know, in the language I use, sort of a pelvic rotation to the left. Okay, and then I looked sort of at a general thoracic, you know, what do I want to click? Just a thoracic. What's the word I'm having? God, I'm losing my mind here. I forgot the word. Thoracic screen. So she basically her pelvis was to the left, her thorax was to the right. And that's kind of common. I mean, at the end of the day, the body just untwists ourselves just to see straight. The nervous system is real smart that way. And with her, she had a lot of tone in her rectus femoris on that right side. Her neck was completely shifted to the right. She had, I've done some cranial work. She had we call it a temporal intracranial torsion to the right. And I'll just, you know, if anybody wants the exact, you know, details of the evaluation, I'm more than happy to, you know, send them or pop them in on the show notes or something like that. So in standing, I tried to change what the most obvious thing was. And with her, she just stood normally. She had a few twists in her system, but her head was shifted. And I was like, okay, let me just get my hands on her. Let's see if her nervous system relaxed. So I ended up doing what we call I modified or a correction to her cranium. And the minute I did that, her whole body just started to relax and she took a deep breath. Right. And that's the nervous system, right, Susan? Mm-hmm. I think that's the whole, right?
Yeah, absolutely. Anything that changes that fast is neurological.
Totally. And I think at the end of the day, when these people are coming, they're so complex, their nervous systems are so jacked up that, you know, you have to intervene there first, whatever you do, right? So I'm like, okay, she's actually taking a deep breath. So, and I went and I sort of did other modifications to the pelvis and the thorax, and it really wasn't making so much of a difference. And I'm really shortening this up for the mm-hmm. podcast. So then she's like sitting, you know, I really need to sit. And I said, okay. So I don't do like your, you know, lumbar forward bend, backward bend. I don't do, you know, much of that much anymore. I mean, with her, she had to sit well. And so in order to sit, she has to squat, because how do you get to a seated position? She have to squat. So I said, just show me how you sit. Just squat for me. Every time she squatted, her head shifted to the right. It was just wild. I mean, it literally shifted to the right. And I said, there's got to be something with the neck. And I started questioning her a bit. She's had on and off neck issues over the years, but nothing really that would drive her to see a physio, right? So now that I've treated her and discharged her, I will tell you why the neck came into play. She had a foot issue many, many, many years ago. And every time she walked, in order to make sure she was walking okay, she would look down to her right foot. And that was a pattern over many years. I think she just did, and it became ingrained in her brain. And so
Yeah.
that was her motor strategy. And I think that's why it goes back to the story. It's the power of listening to somebody. And she did tell me she had that foot issue, but I mean, she didn't tell me she kept looking down. Why would she? It's not something that would even enter her brain, right? So anyway, so I watched her squat, and she had her typical twists. And what was interesting for me was that the twist in the pelvis was worse. And I said to myself, it has to be something in the viscera, something down low in the pelvis that's pulling her, that's driving that twist. So, but I think that was secondary. So I did the same thing. I went into the neck, and I started to just correct the neck. So just backing up, when she did squat, she felt her pain on her right side. So this is all, I haven't gotten her on the table yet at all. So she had the pain in the right butt. So when I had her squat, neck shifted, pain got worse. I said, okay. So when you imagine her whole head is shifting to the right, her whole center of mass is probably shifting to the right. She's squatting, and she's tensioning that right SI joint, or right part of the pelvis. So I ended up correcting her neck, taking the twist out. I'm using my hands here on the podcast.
Like everybody can
I
see
know.
this, right?
It's like, I know. So just suffice it to say, we did some modifications to her neck. I kind of got her over to, I just basically centered her center of mass. At the end of the day, when people, if it's an obvious gross shift, or, shift to the left or right, you kind of need to center their center of mass. So I did that via her neck. Then she squatted, and she had no pain. And I was like, she was blown out the door, and I was blown out the door, because all I did was make it, shift into her neck. And once again, it was probably a learned motor strategy, never got treated. And, she did get better over the years, but it never stuck.
I love the way that you're talking about this ingrained motor pattern, because I think when we see these complex patients, and these patients who certainly have these pain experiences for as long as they have them, that some of these patterns are there for a reason. And why did they adopt those patterns in the first place?
Right.
And I love the idea that you can take something, and you can call it, everybody out there, whatever you want to call it. I think what we don't know is why things work, but my bias is that I think we're really just kind of nudging the neurological system. And when Erica talks about taking and just all she's doing in the neck is just helping them move in a different way. It's a novel input into the system. And how many times has this patient been whacked and attacked and told she has a terrible piriformis, and told she has SI out, and all of these different things out there. And all you did was you took a look from a different point of view. It's like, right, rather than looking down into the pelvis, let's look up and see, right, what is that pelvis balancing?
Right, exactly.
And, and so you just changed it. And so all of the neurological pieces that come in there, wow, there's the vestibular system, there's the eyes, and the whole eye motor cervical complex. And all of that has to work in a little bit different way when we move that head. And trust me, 50% of the body's proprioceptors are in the suboccipital area. It's an important thing to know where our head is in space. And when it's been in a certain position for a long, long, long time, nobody's ever listening to trying to move it out of there, because that becomes the normal, right?
Exactly.
That's what that brain is listening to all the time. It's like we are fixed to where those eyes can see the horizon, and this is where we live. And then when you change, and you just offered her a change.
Yes.
And let her central nervous system sort it out. And because her brain had to think about something else, it got her off that pain experience racetrack.
Yep.
Even though, briefly it did. And so all of a sudden now there's a difference.
Yep.
This was like this, and now it's like this,
Yep.
It's very cool.
Yeah. I always think of that homunculus that I learned with in Explained Pain with David Butler and Lorimer Mosley. Her, like a piano player, their fingers are huge, their representation in the brain is huge. And so for that motor pattern, that was her path of least resistance, know, and I think that, and that's her, as you said, her norm. So we made that change. And then this whole thing with the knee extension started to really get me. And I said, let me get her on the table. And so I'm just looking at the evaluation, because it was a few years ago. So I basically did a basic slump test on her, because she has to sit. She's in this Barca lounger. She's slumping. She's not sitting perfectly straight, which is fine,
Right.
So I ended up doing it, which was interesting, because when I did eventually slump her, when she did her knee extension, when she kicked the right leg out, it made her worse. So I'm not sure when she said to me in her story that when she sits and straightens her leg out, it makes her feel better. But when I loaded her system and I slumped her pretty deeply, she did the full slump, cervical flexion, knee extension, made it worse. So then I just did the, cervical extension, eased the symptoms. So what I ended up doing, and she had a lot of symptoms there. So what I did end up doing is I corrected the cranium again in the same position, because with these patients, from my experience, is that if they've had an issue for a long time, they may have secondary issues that need to get treated, which she did, but the primary issue tends to be similar across, we call, function, right? So I corrected the cranium. Her slump was pain-free, and she started to lose it. She was almost crying, So, and once again, the input into the nervous system.
Mm-hmm.
So that's when I said, okay, I need to make a change the first visit. I didn't need to treat her. That wasn't treatment, but I did show her that we could make a change quickly, right?
See, I'd have to disagree with you there. I would say that is an intervention. Whenever the system changes, right?
Right. Fair enough. Yeah.
Uh-huh.
Yeah.
That's not one that we're used to thinking about as physios, right. That it was just so easy. Did I really do it? And it's like, well, you were the facilitator to the system.
True. The evaluation becomes the treatment.
Yeah, exactly. Right.
True.
How is this going to be different if we do it this way? Yes.
Yeah, totally. So then I said to myself, based on, the first visit, I went in and I did some analysis on her neck. I've taken a couple craniosacral courses, and I've done, just an intervention. I released some of the muscles. I went in and did some, I'm not going to go into the whole craniosacral stuff, did some work on her sphenoid and things like that. And found, at the end of the day, I got her up off the table and she squatted, did her slump. She was pain-free. I knew that wasn't going to carry over. I had to give her something to do. Okay. Like some mental imagery, some form of cueing to really, it's that looking down at her toes, an ingrained pattern. So in some of these courses that I've taken with, Diane and LJ, they talked a lot about, with the cranium, different cues. And with her, you're not seeing my hands on this podcast, but with my hands, I explained to her, this is what's happening to your system. We want your system to go a certain way. And that wasn't working for her. So I said to her, think about on her right side, think about, combing your hair. Crazy cue. But when she did that and I had my hands off, she slumped, she squatted, she had no pain because she was self-correcting via her nervous system.
Mm-hmm. Mm-hmm. She was actually building new patterns in.
Totally.
So these are all motor patterns that we have as humans. We had them all as children, right? But as we develop and grow older, and our central nervous system job is to make things as efficient as possible so that we can live in our cognitively driven world of an anticipatory kind of being able to see the colors and not have to think about where our feet are. But somewhere we lose the richness of that lovely motor stuff. It's all there. It just needs to be rediscovered.
Totally.
And, I love the idea that, so doing the technical thing, like if your system is here, move it here. But sometimes we just have to, we have to come up with, give them some ideas about some visuals to use.
Mm-hmm.
And I think at the end of the day, the visuals have to be theirs. They got to bite, it's got to be something that sings to their system. Or as my friend Joe Brents would always say, I love this line, I steal it from him all the time, is whatever it is that strums their central nervous system.
Right.
You got to find that, and then they need to latch onto that and begin to that, because it's so uniquely theirs. I mean, the next person who comes in, a guy, would never think about combing their hair on the right hand side.
I know. I would have to come up with a different cue.
But that's what I think makes this so much fun.
Right.
These folks is that, wow, it's exciting to get creative.
Yeah.
Okay, well, all that normal other stuff you did 1,000 times didn't make a difference. So let's do something totally different.
Right. And it has to be. What's the research? You would know better than I would. Like mass practice focused work. Like she's like, how many times should I do this? I'm like, kind of like 30 to 40 times. I mean, you tell me. I'm not up on that latest research.
Right. So I think in the beginning, the mass practice stuff is really important when you're just trying to begin to start putting a new pattern in. And then when you get into skill development, you have to vary the function, right? So the 30 to just give her something to do, something that she can think about differently than whatever she was thinking about. I love it.
Yeah.
And within a specific task that isn't overwhelming and something that she's able to achieve on her own.
Right.
Right? Because when we move to skill, what would we do? We'd make the chair higher. We'd make it lower. We would do that, going to the toilet. We'd do that going to the ground and coming up. We would do that in and out of the car. And, and so as we vary the function and the whole thing, then you begin to, vary the variance around that new pattern that she's using that changes her pain experience.
Right. And with her, a squat, that's, for some people, that's a lot of load in the system. So you could break it up and do, I'm not a big believer in giving 50 million exercises. I think at this point, it's ridiculous. So, they can go on a leg press or like a reformer and do a simulated squat. They could do an assisted squat with like a TRX or a rope and do it with that cueing. So some people, I'm not about to reproduce her symptoms every time she does the squat. And if her brain isn't understanding that cue after 15 reps or she's failing there, then she needs to take it down to an unloaded position, and that's what we did with her. And I think, at least with the evaluation, I think it's important to note that I didn't do any special tests for the SI joint or, any of those things. And because I don't think that at that point, she doesn't need them, and I didn't feel that it would have been helpful to my clinical reasoning process.
Right.
To be honest.
I agree. I think sometimes what ends up happening is, as much as we all know that where pain is being expressed somatically isn't always the place that needs the intervention. However, we can't help it. It's like moths to a light. Yep. We are just drawn to it, and they want us to be drawn to it. This is where my problem is. Everyone come in and be here. Yep. And it's the interesting thing about these folks is in the beginning, they're not real happy when you're doing other things. It's like, I came in for this, I didn't come in for you to grab my head and push it this way, so to speak, but when you begin to, bring home the point of, how this is going to change and how, your brain needs to listen to something different, then it, and they can get, even if it's for 2 or 3 seconds, that something changes.
Yeah.
That buy-in is so important.
Yep.
Because I get asked this question a lot with a patient like that, because obviously being more of a bend with women's health as well as orthopedics. Everybody who comes to me has some sort of something around the pelvis or the hip. That's, my jam. That's why they're in my clinic. And I can tell you, I spend very little time hanging out in the pelvis. I spend a lot more time thorax, neck, voice, throat, feet, knees, just anywhere. And sometimes, in patient, we get this all the time, right? That when she was talking to you, did she say to you that I have my pain all the time?
Oh yeah, constant.
Yeah, constant. Never goes away. Never.
Right.
What makes it better? It's never better. Right? What makes it worse? Then they can tell you what makes it worse, but it's never better.
Right.
So that tells me right there, they've lost the ability to listen to difference or contrast in their system. And so when you can get that, however you can get that, I think it's really, really important to begin to start going, because, we know that all those pieces in the brain, and I'm using my hands now, pointing to my head, all get hijacked into this loop, which I like to fondly call with my clients the racetrack.
Yep. That
really efficient pattern that gets placed in there, and it's so efficient. There's deep grooves, so it's real easy to fall into that, right back into that pattern again. And so I love the idea that you made it real simple for her, and you just said this movement. Let's change this. Use this visual that you and her came up with that strummed her nervous system, and just take that simple thing and pay attention to it, so that now she has the ability over time for her brain to go, okay, if I go this way, that starts to wind up that system again. If I go this way, it's not. It's different, right?
Yep.
And so she's beginning to learn which is really important. Gosh, I sound like an old school teacher. Been here, I learned.
But it's true, though.
But she's really beginning to recognize that her system can do the same movement a different way and have a different result.
Yeah.
And I think that's what we're after, right?
Right. And I think you mentioned learning. It's true. I mean, I did not ask, but I do now. How do you like to learn? What's your preferred learning method? Visual.
Great.
Some people are like, just give me a ton of exercises. That's the way I want. Okay. Fair enough. But, and I don't do a lot of that. But if someone really, that's the best way they're learning, then I'm going to give them a few things to do. Very didactic. But I think with people who, are more visual or have that sort of better, more sensory input, that better sense of kinesthesia and proprioception, those cues, I think, help. So with her, what I ended up doing, I was just rechecking, I did give her some, slump sort of sliders and neural glides for her home program with her cue in an unloaded position. And I did some easy sort of, she didn't have access to a gym or any of that, so I just did some assisted squats, 2 things, period, end of report. And then I told her to be aware when she's walking or sitting, just be aware of certain patterns. And I think that for her, it was an eye-opener. She's like, oh my God, I spend all my time on my right side when I'm sitting, or when I'm walking, I'm looking down. That's how that came out, So I think being aware of the issue is 50% of the problem, because if they're nervous and can correct it, that's great. Our job's over, right?
Well, then our job really becomes fun, because then it's like, okay, so how can we challenge the system a little bit more?
Exactly.
And get them going beyond, and then rechecking in on goals, right? How much over the course of treatment did her goals change from just being able to sit, to drive to work and walk for 30 minutes?
Oh, I mean, yeah, she wanted now. Yeah, I mean, she was able to drive. She's like, I take a walk around, the lake a few times at lunch. I'm like, okay, how long is that? Take 45 minutes. I'm like, okay. And I want to sit in this big lounger, and watch TV at night for an hour or 2. And I said, okay. And so they changed. Hey, everybody. Thank you so much for listening to part 1. Susan and I had a fabulous time, and we really enjoyed it. And it turned out to be a little longer than we thought, which is typical with complicated patients. So this is the end of part 1, and stay tuned for part 2, which it will be the second part of the podcast. Have fun and enjoy. Thanks a million.